I'm Helen West. I'm the Deputy Associate Director for Cancer Services here at UHCW. It's a varied day in this role, and I would say we don't have a typical day. We have some core things that we have to do as part of our role. For example, we manage all the cancer MDTs, which are the multidisciplinary teams for the Trust. And so there are 18 multidisciplinary teams that don't happen weekly, but about 14 of them happen weekly. And they are meetings that cannot be cancelled. And so I have a core team of about 9 staff who I manage, who organise these meetings. So that's a main part of my day and my week, is making sure that these meetings are organised and carry on. So that's quite essential. And what falls out of these meetings is obviously patients with a cancer diagnosis are discussed, and then it's we have to collect the mandatory data about all of these patients. Part of it clinical data, part of it just general data about when they were referred into the Trust, when they were seen, when they were treated, and sort of what their outcomes are. So we have sort of quite a lot of data that's collected as part of the multidisciplinary team meetings as well. We deal with COSD, which is a Cancer Outcome Services data set, which is mandatory government data, which has to be collected on any patient with cancer, from their date of referral to their diagnosis, treatment and care. And then there are specific data items depending on what cancer the patient actually has. So there are specific data items per each tumour site. But we also have to collect data for the national audits, which there are 4 national cancer audits. So that's more specific data that we collect. And then we also have the government targets of data, which is referral into care. Patients have to be referred and seen within 14 days, and then preferably diagnosed within 31 days and treated within 62 days, and that's basically government data, and we sort of coordinate all of that data.
So I get the sense that you're quite a coordinating role with the MDTs. Can you just talk a little bit about that, and also how it's changed over the time that you've been doing your job?
It is a coordinating role. We do need to make sure sort of the right people are there, sort of in the right place, and that the meetings happen. And as a general rule, it's a very sort of staple part of clinicians and admin people, whoever's involved in the MDT. It's a sort of staple part of their week, so people do turn up, these meetings do happen, and outcomes are recorded. How it's sort of changed recently is it used to be quite sort of more of a paper exercise. There was a lot of sort of things being written down, a lot of photocopying, maybe sort of more long-winded, but over the last couple of years we've introduced electronic MDT, so all the multidisciplinary team meetings are electronic, so it's electronic generated agenda, electronic generated outcomes, and also they can be immediate data input in the meetings. That is quite difficult because the meetings are really busy and they are going from patient to patient to patient, so it is quite hard to do everything sort of in real time, but then the outcomes are done straight after a meeting. And I've got 2 meetings now where they're doing outcomes within the meeting, so they're actually validated, the outcome is actually validated within the meeting, and that is straight away put onto our electronic patient system, onto CRS, so there's a sort of an immediate outcome for, say, a clinician who's referred a patient in, they will get an immediate outcome, which is good for the patient, good for patient care.
So preparing for an MDT has changed quite considerably over the past few years, I understand. Could you talk a little bit about how that's changed?
I think the main thing is it was very paper-based. There were sort of paper-based agendas, people scribbling on bits of paper, and then obviously the outcomes being printed up into Word documents and being sent out, and people printing off their outcomes. And now that's not necessary because it's an electronic multidisciplinary team meetings, and so it's electronically created agendas and electronically created outcomes. Though if I'm being honest, people still do like paper and they do like to print them out, but we have got laptops for the meetings that people are starting now to become much more IT sort of literate and looking at things on screens rather than printing out paper, which we had in the past.
What are the main challenges that you face within your role?
The main challenges are that hospitals are very busy places, and I'm focused on a patient on a cancer pathway, trying to get their treatment sort of coordinated and delivered within 62 days. But there are a lot of other patients in trusts. It's very busy. Other teams have got lots of other targets that they have to be able to deliver their care on, for example, the 18-week target, all the pressures that are in the press at the moment about the winter pressures and patients in A&E and no beds in the hospital. So it's sometimes quite hard to get the teams to focus on the 62-day pathway. Not that they're not bothered, it's just they've got a lot of other pressures on their time as well. And so one of the problems is engagement with the teams, and not so much the clinical teams, with the managers who are very busy, to get them to prioritise my priorities.
So the main metrics that you were measured on is the length of time it takes to get patients through the care pathway, is that correct?
Yeah. Well, they're the immediate ones. Now, because of all the data that were given to the National Cancer Registry through all the national audits about mortality, 30-day mortality, 90-day mortality, and actual outcome data, that's becoming more into the fore. So, but your more immediate ones are the government national cancer waiting time targets.
And it all sounds like it's clinical outcomes that you measured on.
Yes.
Do they find any financial?
There are new techniques that come in. So one of my problems at the moment is they're doing, which is good, we've got the robot, so you're doing your robotic prostatectomies, but they can only do, instead of doing maybe 4 in a day, they can only do 2 in a day. And so because it's a new technique, it takes longer, and you've got to sort of develop skills and so you're a little bit slower, which is fine, which is a better treatment and ultimately a better outcome for the patient. But from my point of view, there are less patients being treated, and so it's slightly harder to hit targets at the moment, but the ultimate outcome is better patient care. So we manage the cancer peer review programme as well, so that's all the multidisciplinary teams. There's very specific guidance from the national peer review programme about how an MDT is structured and the function of the MDT and who's at the MDT, and more importantly now it's all about patient populations, that you have to have a certain size population and a certain amount of operations going on to make you a specialist centre, or whether you're having to sort of work with other centres, for example UHCW working in conjunction with UHB or something like that. So we manage all of that programme for all the MDTs as well, which is good. I think it's a good programme because teams have to have an operational policy for how they function, which is good. They have to have an annual report, so they're looking at what they've done in the previous year and what their achievements are and maybe what some of their difficulties have been. And then they have to have a work plan, which is obviously the things that they haven't achieved as well or actually managed to do within the year, they're moving on to a work plan to try and achieve in the following year. So it structures the MDTs a little bit. That's a little bit of a bureaucratic sort of administrational process, but actually it does make the teams think about how their structure and function.
It sounds like your responsibility is a lot to do with building but also maintaining this hospital's status as a centre of excellence.
Yeah, I think we do. What the beauty of our role is we don't have a budget as such, but we have overall oversight across the whole of the trust for all cancer services. And if you think about a cancer patient's pathway, that's virtually every service within the trust a patient will hit. I can't think of any service where we don't have some contacts. And it's not just the frontline services, it's the pathology departments, it's the radiology departments, it's the impact on those departments as well, with patients coming into the trust that need the diagnostic investigations before they can get treated, and we have that influence there, or have an overview of what is actually happening that we can then report us sort of up to the executive level so they're aware, and to the chief operating officer, so they're sort of aware of the situation.
The good side of your role, what do you find is the most rewarding aspect of what you do?
I'll think about this. Well, it is rewarding when we hit our targets, because even though it's not me doing it, it's more facilitating and working with the teams. It is quite pleasing that I do know, because it's a sort of, I've got a main tracker and we're tracking patients all the time. So we have 1,400 patients referred to this hospital on a 2-week wait, and my team will track all of those patients. The vast majority of them won't have cancer, but then the ones that do have cancer diagnosis and go onto a pathway. I mean, I can say that the vast majority of them are treated within 62 days, which is a good thing. So it's good that we hit those targets, and we're one of the highest performing trusts in West Midlands and East, I would like to mention. so we do, yeah, sort of hitting our targets. That my staff come in, that my staff are happy, we have a good team, and it's good when everybody's sort of working together. I mean, that's good.
We've talked a lot about patients, and it is satisfying to make sure that patients who need it are got through the system quick. It improves their clinical outcome. But is your view of the patients really based in the data and the statistics and making sure that that happens? Or do you actually get a sense for patients as individuals as they go through that journey? When
we're tracking a patient, you do get a sense of a patient as an individual, maybe sort of one step back, because you're looking at the letters that the doctors have written about the patients, and you're looking at how the patients have been cared for and the decisions that the doctors are making, and you think that's not the patient. That patient's having a pretty good pathway. Some of these patients are quite old. A lot of them have got comorbidities, and how they've been managed by the teams, and how their care has been managed and planned. I think you do get a sense of it in that way. And also, we are the point of contact for a lot of clinicians, nurses and doctors who come to us talking about patients or their pathways or things that they want to get improved. And so we're sort of that sort of hub, and we do sort of then contact and initiate and sort of push things. So we're not directly involved with patients, but we're sort of that one layer behind, I suppose. But you do get a good feel of patient care.
Can we talk a little bit about the team that you operate with, and who's in it, and how it works?
Yeah, so we're quite a small team. There's a trust lead clinician who is actually a jobbing clinician, so it's just he's got some PAs where he supports the cancer team, but it's quite a useful role because they have obviously influence with their colleagues, and they have a good overview of what's going on in the trust clinically. But there's a lead cancer nurse, and the lead cancer nurse role again is a role working very closely with all the cancer clinical nurse specialists and having a voice for cancer nursing across the trust as well. And then there's all the multidisciplinary team facilitators, but our core team is the lead nurse, the lead manager, the lead clinician, and then our executive lead that we link into.
Let's talk a little bit about the public health campaigns that you tend to get involved in. What is the impact of those on the hospital?
Well, it's just you get a notification. So you get a notification from the government that they're going to have a health campaign, and that trusts need to think about what they need to have in place, because there might be an increased number of patients being referred to the hospital. And in the general case, maybe it's not as many patients as they say, but you do definitely get an increase in referrals to you. And there's a massive, that is quite a big impact. For example, at the moment, it's Be Clear on Cancer for esophageal cancer. And so a patient being referred in has to have an endoscopy. It's a one-stop clinic, and they go straight to endoscopy. So you've got to have that capacity sort of created up front. And we have just about got the capacity for the patients now, but we're thinking there might be a 20% increase. So the department have had to plan for that. And with winter pressures and with everything else, that's quite a significant thing to have to plan for. There's been the hematuria campaign for people with blood in their urine to go to the GP. I think there's been recently the Clear on the cough. If you had a cough for more than 3 weeks, go to your GP, and you get referred in. And that's all pressure on trust to have the capacity to see these patients. But the rationale being that you're trying to diagnose a cancer patient earlier, because a patient that's diagnosed obviously earlier will have a better outcome, and will be much more easier to treat a patient with an earlier cancer than a patient with a more advanced cancer.